Hello, everyone, and welcome to the Trauma-Informed Care and the Long-Term Care Organization video series. This segment is titled Trauma Screening. My name is Paige Hector, and I'll be teaching this video today. I am an advanced practice social worker working in post-acute and long-term care for over almost 30 years now. I'm very passionate about a variety of topics, including trauma-informed care, clinical operations, and process improvement. I do a lot of writing, including a couple of columns for two well-known publications, and I'm involved in several national work groups and committees. My bio will be available at the end of the presentation. So here we are. This is the list of the video series, and like I said, we are going to be talking about trauma screening today. The topics are going to include the difference between screening and assessment. I'll talk about capacity in screening, direct and indirect screening barriers, and discussion prompts for all 6 of the trauma-informed care principles. So I just want to lay a foundation here that in general, there is a difference between screening and assessment, and this is really, really important when it comes to trauma-informed care. So generally speaking, a screening is something that's brief. It's used to identify whether further evaluation or assessment is needed. For example, a physical therapist can go in and do general screening to see if the individual can do their basic daily care or get up and move and transfer. If they can do all of those things and there's no pain or discomfort, chances are there's no need to do a full physical therapy assessment. Same thing with, so a hemoccult test, which is simply a test that detects blood in the stool. If it's negative, there's no need to pursue a colonoscopy. If an individual has suicidal ideation, which I identified in the PHQ-9, definitely need to assess for suicidality. So the screening is like the precursor to an evaluation or an assessment, and that language is very important when it comes to trauma-informed care. So the role of tools, we tend to think of, well, there's a tool or an assessment tool or a screening tool that we have to use, but I love the work of my colleague, Dr. Farini, and she talked about the role of tools in assessment. Basically, every tool is flawed, and I think if I were to ask you, do you have the perfect tool to really screen anything, whether it's falls or bowel and bladder or trauma-informed care, or the perfect activity assessment tool, or a biopsychosocial spiritual intervention assessment or screening tool? The answer is no. There's not one perfect tool. What she talks about is the very best tool is an experienced creative clinician, asks great questions, who is caring, listens to what is said and not said, and then tailors it to the individual at that point in time. So things like, well, what does this individual want or need? What are the risks for them? What do they say or what do they do? So it's really, to me, there's a lot of critical thinking skills when it comes into screening and doing some assessments that we do in the post-acute and long-term care setting. So a true assessment is not a checklist. It's not a form. It's a skilled clinician asking the right questions, listening and observing, and then ultimately making a decision about what are some options for the next steps. A real assessment, and again, this is just a list of all the different things. So when we start thinking about trauma-informed care and screening, it includes observations over time, interviews with the individual, the staff, the family, a physical assessment in some cases, review of records, behavioral issues and triggers and what therapies have been tried and what worked and didn't work, the relationships that you build with people. All of these things contribute to a true assessment in a very broad sense of that term. So let's delve into a little bit more deeply the difference between screening and trauma assessment. Screening. Basically, all of us that work in long-term care, we can be considered generalists, and there might be a few exceptions, which I'll talk about in a moment. We all need to be ready and trained to notice and respond. Notice what might be a potential trigger for an individual. Is something that we're doing or in the environment re-traumatizing for the individual? We are not going to be asked to treat trauma. What we do need to be able to do is to know when there is trauma or a possibility of trauma, and then we need to be able to refer that individual to a specialist. So a specialist is someone, like the name implies. Perhaps it's a psychologist or a psychiatrist, a mental health worker or a social worker, a clinical person that has very skilled training around trauma-informed care. This is a person who is skilled and qualified to do an evaluation of trauma and to develop a treatment plan. So a trauma assessment, this is something that most of us are, again, considered generalists in the long-term care setting. Unless there is specific training, experience, and background, most of the trauma assessment would be done by someone outside of the nursing home setting, a mental health professional with training. So really think about who are those individuals in your particular community, how do we access them, how do they get involved, and then ensuring a consistent process for communication. I never want staff to be afraid to do screening, to screen for trauma. But there are a few tips around this and some things that we do need to understand. By simply asking questions around experiences or perceptions of trauma, the chances of us re-traumatizing person are much less than if we do not screen. So I know that some people say, well, I'm afraid to ask those kinds of questions because I don't want to re-traumatize them. But the reality is that by asking those questions, we're doing more of a service than by not asking at all. At the same time, just talking about trauma does not create instant catharsis. Okay, just because we bring it up or we talk about it, it doesn't mean that it's been resolved. We need to be mindful of what we are asking people and be prepared to respond and know what next steps or resources are available. In this resource here, all these resources, by the way, are free. They're readily accessible and downloadable. This particular resource did a lovely job of providing some guidance of what if questions. For example, well, what if I can't cope with what the person is telling me? Or what if they reject my concerns? What if I kind of know that something is just not right, but they don't seem to be wanting to share that with me? These are all the kinds of things that when we, as generalists, begin to move towards screening for trauma, we need to have some understanding of how we would react in these situations. So there's resources out there. I'm not going to be going through these in this particular video, but the resources are there. I encourage the leadership in your facilities, the people who are going to be doing some training around trauma-informed care, are aware of these and incorporate this information into your training. The bottom line is that we can harm an individual. And the quotation to me that sums this up very well is that while non-clinical workers who are trained can provide the screening, they need to understand their role is to provide validation and supportive responses. So when an individual says something, like my husband wasn't feeling well when he went to bed, he never woke up and it's my fault. Or I was just diagnosed with lung cancer and I'm so angry at myself for not quitting smoking when I was young. Smoking helped take away the pain of losing my child. So we need to be aware that when we open this kind of that Pandora's box idea, we need to be aware of how we might respond in some of these types of situations. I encourage staff to consider what their scope of practice is. Now, for nurses, a scope of practice concept is much more familiar and understood. For example, myself as a social worker, I know very clearly what my particular scope of practice is. So we all need to be aware what our limitations are, our experience and our knowledge. And I have a colleague of mine many years ago, Anita Royal, who was the county public fiduciary where I live here in Arizona. She said, practice in a manner that is consistent with your skill level. Practice that is consistent with your skill level. For example, if you in your community or your facility is being asked to do a trauma screening and you don't feel prepared to do that or trained, It's your responsibility to speak up and say that. And at the same time, the leadership, as you begin to think about how do we bring trauma screening into our communities, we need to make sure that the staff that we ask to do this, that they are fully prepared and comfortable, because really we can cause harm. Now, screening for trauma can be done in a variety of different ways, mixed formats, self-inventories like a self-assessment type of thing, or a self-screening worksheet, checklists and questionnaires, interviews, dialogue, or any combination of those. So when you think about, well, how would I introduce the screening? How would I even start that conversation off? Here's some ideas. You could say something like, you know, many people have had difficult experiences in their life. I'd like to ask you a few questions about that. Is it okay? And then at any point in time, if the individual says no, I say respect the no, acknowledge it, go ahead and document that they've declined to continue that dialogue or that they chose to. Please don't say the word refused. That's really very paternalistic in a sense that, you know, people have a right to not want to talk about especially sensitive topics. So we just need to uphold dignity around that. So there's a couple more prompts here as you begin to open this dialogue and begin the screening process. Again, to recap, what we're looking for in screening is triggers. So again, a trigger is anything in the environment, a smell, sound, emotional state, anything at all that can remind a person of a past traumatic experience that would then impact them in feeling re-traumatized, as though they're living that experience all over again. So the screening is going to focus on triggers in order to avoid re-traumatization. Just a reminder here, this is something I talked about in the first video in the foundation, the universal precautions that no matter what type of screening your community does, what screening tool, what process, whoever does it, we always want to make sure that we are using universal precautions. That even when an individual says that they don't have an experience or a traumatic experience, we want to approach everyone, residents, family, staff, care partners, as though there could possibly be a trauma background. We are focusing on triggers and symptoms and expressions of distress, and not the trauma event. And that's really, really important. I'm going to bring that up again and again. So I'll talk more about that in a little bit. As we talk about people, as we talk with people about their traumatic experiences and how it's affecting them currently, a lot of times we'll learn about the event itself, which is okay. If people voluntarily share that information, it's fine, but it's not what we begin the discussion with. I'm going to show you some different tools and make that very clear in just a moment. So re-traumatization from COVID, these would be some examples of how a person might experience being triggered by things that are specific to the pandemic. So as we go in and we screen people, we want to be aware of things that have happened, whether it's the pandemic, issues in their past, but the focus is how they're experiencing them currently. So let me just show you several more triggers that actually may re-traumatize people. And these are what we're looking for when we screen people. So again, multisensory, sight, sound, smell, taste, and touch, Old Spice, or any kind of a smell, cigarette smoke, a beeping noise, light, ceiling fan blades, invasions of personal space, heat, pressure, feelings of shortness of breath. Like if a person putting the blood pressure cuff on their arm and that sensation of the pressure being applied, being elevated in a mechanical, like a Hoyer lift, excuse me. Those are all things that can be very traumatizing for people or trigger them to remind them of something that has happened in their past. Obviously, pain can be a huge trauma trigger. Feelings of fear and helplessness, power imbalance, feelings of not being heard or believed or understood, being crowded or immobilized, different interventions, dental work, unable to communicate. There's so many different ways. So these are the things that we're looking for when we do a trauma screening. Here's a bunch more specific to medical settings and contexts. So loud noises, falls, nightmares, blood and other bodily fluids, side effects of medication, direct personal care. Obviously, things like the intimate care that we provide in nursing homes, personal care, bathing and dressing and all those sorts of things, being in the dark, difficult conversations, being without clothes in front of other people. All of these things can be reminders of things that have happened in one's past that were traumatic. So looking and listening, indications of prior trauma. This slide is really lovely because these provide examples. If a patient or a resident or a family member says things like, for example, I lost my soul. I lost my soul after, and then fill in the blank. If I had just, he or she would still be here today. They've never been the same afterwards. My whole world was turned upside down. These are absolutely indications more than likely related to some kind of traumatic event. The other indication of long-term care residents with potential prior trauma, if they have been diagnosed with post-traumatic stress disorder, and again, remember the high likelihood of people who have been in the ICU that go on to develop PTSD, people with a history of alcohol or drug use, homelessness, unfulfilled longing, suspicion, agitation, nightmares, all of these could indicate some kind of trauma history. So I showed this slide in the foundation slide, but again, it fits very nicely in the trauma screening, is that in and of themselves, any one of these things could be related to a trauma. I mean, going through a divorce or being in a combat situation, bullying as a child, a medical crisis, all of these can bring up traumatic experiences and trigger them. They can also be connected. And I think that's one of the most fascinating things with trauma is that trauma is cumulative. That the things that I experienced as a young child or a young woman or middle age can impact me at some point when I'm in my 80s. So they're related, and there's patterns here. And this is what we are looking for with trauma screening. When a person is triggered, what that really means is that they feel that they are not safe, they can't protect themselves, or they could actually die. So the triggers cause the re-traumatization, and these are the things that we're looking for when we screen to try to avoid. I love this quotation. This is a trainer with the EMDR Institute, and she said that when current events or conditions share similarities with past experiences, the individual may react in ways that exacerbate their current difficulties, making it even more challenging for them. So I think that just gave a nice context to when people are feeling, frustrated and helpless and powerless and in pain and hurting and disoriented, they might behave in ways that actually make the situation more difficult, not just for them, but also the staff. So we'll be talking a lot more about empathy and how to bring more empathy to these situations. We start by understanding that perception. So it is not important, it is important to remember that what happened is not nearly as important as what the trauma means to the individual. So again, all of us that have experienced, we've all lived and experienced in some way, shape, or form the pandemic, but all of us will have different experiences with that. Some of us may be traumatized, some of us may not. Some may experience post-traumatic stress. Some of us might actually go on to develop post-traumatic stress disorder. So the importance of perceptions here is key. It's what the experience means to the individual, not my interpretation of it. So trauma screening and limited capacity. So want to make sure that we understand that just because a person has limited capacity, for example, because they are living with dementia, or they have a traumatic brain injury or another illness or condition that makes it difficult for them, it doesn't mean that we don't screen for trauma. It just means that we go about it a little bit differently. One of the key things, though, is that when we screen for trauma, we can determine that even if we don't know if there actually is trauma or not, there can be enough indications to act as if the person is experiencing post-traumatic stress. And this is where all of our observations and talking with one another and getting perspectives of the family perhaps can really help us to understand this person's experience of their current situation. So again, capacity determines strategy. It does not exclude anyone. There's two types of screening that I want to talk about right now. There is direct screening and indirect screening. Understand, no matter what we do, no matter how we go about screening, we will not capture everyone with trauma up front. This really makes it important that we continue to keep trauma screening at the forefront of all of our dialogues, our discussions in our interdisciplinary team meetings, our morning meetings, or stand-up, or care conferences, or just general interactions. So direct screening is most appropriate when the individual has capacity and they agree with being asked questions. There are no evidence-based instruments that are validated for people with limited capacity or impairment. So we're going to do the best with what we have, in other words. So I'm going to give you one tool that I will recommend, and it's the Primary Care PTSD 5. So Primary Care PC, Post-Traumatic Stress Disorder 5, because there's 5 questions. And if you'll notice here, I've highlighted the word current. This is really, really important because this tool does a great job of screening for current symptoms. So here's a screenshot of the tool. So you'll see here, in the past month, have you had nightmares, tried hard not to think about events, been on guard or watchful, felt numb or detached, or guilty or unable to stop blaming oneself? If the person indicates more than 3 or more to these, what that indicates is that they are optimally sensitive to PTSD. So 3 or more. Whatever screening tool that your facility decides to use, what's really important, everyone, is that we don't just look at a particular tool in time. And this goes for any screening tool. It could be for falls or pressure injuries. That we look at these tools over a period of time, that we don't just look at the tool that we just did, because what I'm looking for are fluctuations and changes over time. Now, this is a modified version of the PC-PTSD 5 that I just showed you. And what you'll notice is a little difference here. There's a little bit more verbiage here in the introduction part. So it's not just in your life, but it's in your life. Have you ever had an experience that was so frightening, horrible, or upsetting that in the past month? So it expands it to over your entire life, not just the past month. Have you had nightmares, tried not to think about it? So it's the same yes or no questions. If they say yes, it's okay at that point. Would you like to share what is bothering you or tell me more about that? That's okay. But if they answer no, obviously accept the no. Just document that in a very kind, compassionate way and move on. Now, in contrast, I want to show you something different. So what I've been talking about here is screening for current symptoms and not the trauma event itself. Let me show you another tool that is more focused on the events itself. This is another well-known tool. This is not one that I believe belongs in the long-term care setting, okay? Life events checklist. So this one here, look at the events here. It has a whole list of events: natural disasters, fire, transportation accidents, accidents at work, assault, sexual assault. And then it says here, look at the categories across this grid. Happened to me, witnessed, learned about it, part of my job, not sure, doesn't apply. So if we have a person do this type of screening tool and they say, yep, I had a physical assault, I have combat exposure, uncomfortable sexual experience. Like, what do we do at that point? So this tool to me is a little bit more, it has its place, but I don't think it's in the long-term care setting, because what we would need to be able to do then is take this to another level and ask, well, how are those events impacting your current experience, your current situation? So for that reason, I would steer clear of this particular tool, but I wanted to show it to you that there are tools like this, and it's not that they're good or bad. We just need to be very intentional and deliberate about what screening tools we pick for our particular setting. And you don't even have to use a tool. You could simply have some questions. These are some questions or prompts, if you will. Have you ever been in a situation in which you were afraid you were going to die? Or experienced something that made you feel less safe in the world or changed you in a way that has made life difficult? Or experience that made it hard to trust or feel happy to express your need and connect? So these are very good questions that could indicate that there is a prior trauma experience. In the event that a resident discloses a traumatic event, and everyone, this is a very busy slide. The purpose of this slide is actually a handout. This could be a wonderful training tool that as we become more accustomed to trauma screening and we are training our staff, this is a wonderful training tool. For example, if a person discloses a traumatic event, respond with validating language. For example, I'm so glad you told me. Thank you for sharing. This is going to help us take better care of you. You do not try to investigate or ask for details. It might come later that that's not the focus of a trauma screening. And then it goes through a number of a lot of what to do's. Document, include the clinical team. But again, we're focusing on triggers, letting the resident know that you'll need to let a few key staff members. This is really trying to honor people's privacy and confidentiality, that sometimes the things that we learn of a very sensitive nature as people share their life histories with us, we have to make a very clear choice of how much and what to document. Sometimes it's not necessary to document fully what they said, but again, focusing on how that experience is impacting them in the current moment. Now, I've talked about direct screening. This is talking about indirect screening. So this can be something, to me, indirect screening can be done at any time. It's what we're doing all the time anyway. During an admissions process or a move-in, day-to-day care, just paying attention to comments and reactions and any kinds of behaviors that might indicate symptoms of stress. When you have sufficient trust with that person, you can ask them directly about that. Hey, I'm noticing that. Or when I do this, you react this way. Would you like to talk about that with me? Or is there something I should know to take that, in other words, to help take better care of you, to make this a safer environment or feel more comfortable for you? So indirect screening, now you might recognize this. The wonderful part about this is that this is actually the primary care, this is the PTSD-5, but what we've done here is my colleague Barbara Ganzel, my colleague that's doing this video series, we're doing it together. She's adapted it and inserted this word right here, source. So for example, if a resident living with dementia is not able to answer these questions, perhaps you're going to ask a partner, a spouse, or a daughter or family member. The source would be the person that you got the information from. So this actually is doubling as a direct and an indirect trauma screening tool, and that could be part of your screening policy and process. Another tool, and this is another wonderful, you can take this, print it, use this as part of your screening process. What we know is that there can be delayed reactions to trauma over several different domains. For example, emotional, physical, cognitive, behavioral, and existential. And the lovely part about this particular tool is that it lists all sorts of signs and symptoms that are most likely associated with these particular domains. And again, you'll notice, so yes, no, and the source. So it could be the resident, him or herself, family member, or whomever. So again, it's really hard to keep in mind all of these. I would never remember all of these possible reactions, but having a tool like this could help anchor me when I go in to screen a resident, to give me some prompts to ask for, to look for, or to discuss in an IDT meeting. Now, there's some barriers to screening. Again, we're back to that perception of time, which I'll briefly touch on in just a moment. It may not be part of our standard admission or move-in process yet. We underestimate the impact of trauma because this is really new territory for our post-acute and long-term care settings, so we're learning. We may not know how to respond when a person shares a trauma. So all of these barriers here would be wonderful topics as you roll out your process, your screening program in your community, for you to make sure that you've addressed all of these barriers. I want to just point out here, I'm looking at the very last bullet point, untreated trauma symptoms of the screener. This is really important, and I will speak to this bullet point in terms of the pandemic. You know, as we all begin to process and to understand and try to make meaning about what we've been through, it could be that when we're talking with a resident or a family member and they're sharing a story perhaps about the pandemic, that might actually trigger me as the screener. So part of your training in your facility needs to be, what do we do if the staff member who is doing the screening begins to feel triggered, anxious, uncomfortable, or fearful, or whatever the word is. So we need to be aware of these things and to make sure that we're talking about them. I just want to reiterate that, you know, when we look at the whole trauma-informed care, this is a lot of stuff. There's a lot of stuff going on, a lot of stuff to learn. And I want to reiterate again, this is a point I made in the foundation video. We think that we don't have enough time. And I know our time is packed. I really do appreciate that. It's very hard to get our mind around how do I tuck in screening with everything else I'm doing. And what I'm saying here is that our perceptions of not enough time, if we can switch that to priorities, that we can change our priorities. We can try to look more creatively of what things can I take off of my to-do list, or how can I delegate or redo my daily to-do list. But this is a tough thing to do, and it really does require collaboration with supervisors and administration. One of the things you can do is take a look at, and I showed you this slide before, ask yourself these questions. Ask your staff these questions, and if any of the answers are yes, I guarantee you that if you start looking at the processes, making your processes more efficient, you will find more time to be able to incorporate trauma screening, incorporate more person-centered care. Now, let's jump back into to trauma screening. In the event that you have a resident or a patient that indicates yes, that they've been screened and there's a likelihood of a positive trauma experience, your policy needs to be clear of what the staff would do next. So for example, a comprehensive assessment by a qualified individual, someone with clinical expertise. This quotation here from this resource really summed it up for me very well. Screening procedures should always define the steps to take after a positive or negative screening. Screening is only as good as the actions taken afterward to address a positive screen. So we can't just go in and screen people without having a plan for what to do afterwards. If it's a negative screen, we need to have a process to rescreen later. And it's not to pester people or to bother people, but we want to always keep our mind open to the possibility that there's been some kind of, especially in light of the pandemic, some kind of trauma background, because a lot of times either the person may not wish to talk about it, which is absolutely fine, we honor that, but it may not be that they even realize that there is a trauma in their background. Critical thinking is a huge part of this. Critical thinking, basically it's reasoning. I always say, well, it's what goes on between the ears and the gray matter. Critical thinking is the process, and our clinical judgment is a result of that process. So when you talk about trauma screening, there's a great deal of critical thinking that has to go into that, that there's evidence that the things that our residents and patients share with us, that we logically follow through with those, that if we identify there's a possible trauma or experience or symptoms or triggers, that the flow of information, the process is very clear in our communications, in our documentation, in the care plan, in our intervention. So it all flows together and makes sense. Now, once again, here are the 6 principles of trauma-informed care. And what I've done in these next slides, I have gone through each of these principles, and I have pulled out what I'm calling discussion prompts, or you might think of them as conversation starters for each of the principles. These questions are person-centered, and what the idea would be is that we incorporate the answers to these questions into the care plan, into the daily interactions with these individuals. So there's a lot in these next slides, and you'll see in a moment what I'm talking about, but use these questions as appropriate for the circumstance in you're in. What I don't want anyone to think is that, oh my gosh, I have to print all of these questions and go through and do all of them at once. Not at all. I simply wanted to give you an overview of some possible ways to go about asking about trauma as related to these 6 principles. Okay, let's start off with safety. Safety is a big one. You might consider asking some of these questions. How would you describe safety? Very simple, open-ended, and you do a lot of listening. What helps you feel safe? So think about your own self. If you were to move into where you work, into your nursing home, what would make you feel safe? How would you know that the environment was safe, physically and emotionally? As staff, what can we do to help your space feel safe or achieve a sense of calm? Is there anything bothering you right now? So I don't want to go through every single one of these questions, but I want to provide these slides to you as prompts of ways for you, as you embark on trauma screening, to think about different ways to go about them. Trustworthiness and transparency. This really is involving decision-making, asking people, how would you know that this is a trustworthy environment? What does transparency mean to you? And you might have to alter those words a bit depending on the individual's capacity, their health literacy. So we would never want to go in and ask people questions using words like this if it's something that they would not feel comfortable with. How would staff create a trusting relationship with you? How would you know that you could trust? Peer support. Again, another way to think about peer support is trauma survivors in some situations. So asking questions like, what would a meaningful social support be for you? How would you like to be engaged with life or in your care, in the life of the facility? So lots of questions. Here's collaboration and mutuality. There is some overlap here. Again, this one really is around decision making. How would you like to be involved? What's important to you? What's important to you for developing a partnership with staff? A meaningful sharing of power. So these are all, again, feel free to modify these to make them work for the specific situation and for the person you're working with. Empowerment, voice, and choice. There's a lot of questions here. Again, there's overlap. What do you feel you need at this moment? What do you consider your strengths? What helps you express your feelings in a healthy way? What, excuse me, what helps you feel hopeful? What do you value? from your experiences, what responses from others work best for you? So in other words, if you are feeling distressed or distressed or anxious, what works best for us as staff to help support you in those instances? More questions. There's 2 full slides just related to empowerment, voice, and choice. So again, these are prompts. Take a look at them. Select the ones that you think would work best for your particular facility, your culture, the residents. Cultural, historical, and gender issues. Asking general questions. Have you experienced discrimination or racism or oppression or stereotyping? Do you have a shared or historical trauma in your family or your family legacy? Can you help me understand how is it you experience joy or sadness? What is important to you for healing? I want to again point out here the concept of cultural humility. I really prefer cultural humility or curiosity versus competency, because there's no way for any of us to know everything there is to know about every other culture. It's much more rewarding to engage in a dialogue with another person to understand, because even if I have, say, 8 people all within, generally speaking, the same culture, they're all going to have nuances of how they've experienced that culture related to their particular upbringing or where they lived or their socioeconomic status. So engage in dialogue, ask questions. So this concludes this particular topic here on trauma screening. And as I will do in all of these videos, I will ask you to think about your action steps. So for example, by next Monday, I will share this information with, so we can begin to think about what might I do next? How can I bring trauma-informed care into my culture? So thank you for your time. I really do appreciate you being with me. The last 2 slides, in case you're interested, is a modified bio for me. And just to say gratitude for the sponsors of this project, the Care Compass Network and the Finger Lakes Geriatric Education Center. Thanks so much, everyone. See you in the next video.